So welcome everybody. Thank you for joining us for our partnership clinic on NCDs. You're all very welcome here. I hope that you'll find the next hour and a half a useful opportunity to, I suppose, dialogue about NCDs and how they affect our partnerships, and maybe what's worked well, what hasn't worked so well, and ways that we can improve our work on this area. So I'm just going to introduce the ESTHER staff. I'm not sure where she is in your screen, but Manus is our intern in the ESTHER program. Manus has just been with us for maybe 3 months now, I think, but has made a really solid contribution during that time and is certainly an integral part of the program already. Many of you will also be familiar with Thora Burgess, who works in the HSE Global Health team. And then David Weekliam. I think everybody knows David well. So I'll pass you over to David. Sorry, David, you're just muted there.
Yeah, thanks very much, Cara, and welcome to everyone. And look forward to having this time of discussion together. And I think this is our second of these clinics. And I think it's an opportunity for us, I think, to share among ourselves. I think it's not about our expertise to share with you. I think it's about all of our expertise and experience sharing together. And it's maybe a space a little bit different than we do in other fora, where we're focusing on a theme and bringing people together whose work is focused around that theme, who might have some common issues, and that I think can open up opportunities for maybe some particular learning, maybe ideas of how people might continue to share learning or interact in the future, maybe to collaborate in the future, and maybe too to discuss some of the challenges that we all face, and maybe having a group of us together to kind of talk through some of them might be very helpful as well. And the first of these clinics we did was on mental health. And this one's on non-communicable diseases. And we're picking for us what we see as some of the priority themes in work that our health service and people working in the health service or in our health-related institutions from Ireland are involved with in low and middle income countries, but also issues that are of particular importance from a health point of view in those countries. And NCDs is absolutely one of those issues. And I know some of you have been involved in NCD work for a long time, but when I go to different African countries now, and this weekend I'll be traveling to Tanzania, and always when we go to these countries, we're asking them, what are your needs? What do you see as your needs? I don't think it's our role to go in and say what their needs are, but so I very much am always in listening mode, and I always hold back. But the one area I don't hold back on when I go to a place like Tanzania is NCDs, because I've seen in Ireland the cost of NCDs to health of people in Ireland and the cost to our health system. And most people who come to our hospitals are coming with an NCD. And I don't know if you would concur, Joe, but I think most people coming to primary care to clinics have got an NCD. And when you think of how much our health system, our health service costs to run, how much these diseases are costing us. And a difference in Africa is that they haven't yet reached the same levels of these diseases that we have in Ireland. But they're on an upward trend. And people often talk about the epidemics of NCDs in Africa. And they have an opportunity, if they act fast, to avoid getting into the situation that we're in Ireland, where the health service resources are being consumed by NCDs, and that people's health, as they live longer, is being overtaken with suffering from NCDs. And it's going to involve, some very strong responses all across the whole spectrum of response, from prevention to early detection, treatment, screening, and treatment, and trying to have people who are got NCDs being managed in primary care so they don't end up needing expensive treatments in hospitals. It's a huge agenda for the countries we work in the HSE. And some of you are in other countries work, I know, but I think in the countries we work with, it's a very big agenda. So I think that's where you say, I think this is one of those important issues that it's good to be collecting around, and it's been very, and I think everyone here actually from who's joined is I think has been connected with the development of the Ireland Africa NCD Alliance. And I think that's a really great development to bring people in Ireland together with this interest to work with particularly in Africa. And so I think there's a lot of kind of collective work going on there, and maybe that, you know, what we do in the ESTHER program can hopefully kind of support and complement that. So I think what we want to do really is open it up for discussion. We're not a very big group today, so it may be that we will cover the issues a little bit more efficiently than if we're a bigger group. But really to generate us to have a discussion and to hear from you, and maybe just invite you just to start talking on the, you know, on this topic of NCDs and the things that we're interested, I think, in having discussion around are firstly, maybe what are some of the key things we've learned from our experience working with other countries on NCDs? Are there some big lessons that have struck us that we think are useful for others to hear and for sharing? And to understand too, what were some of the challenges, maybe the things that obstacles to addressing NCDs we've come up against, or to us working with supporting other countries. What are some of those things, and maybe things that didn't work so well, that no, it's always useful.
Sorry, David, I think
David, you're on mute. You hit the mute button.
been muted there somehow. There we go, you're back again.
Was I long muted? Was I just?
No, just a sentence or so.
Okay.
And I'll just say welcome to Richard. Richard's just joined us there in that moment as well.
Not really.
Welcome, Richard. You're on mute, Richard.
A good sign is to put this up to your ear, and then people can see that they're not speaking.
Richard, we're not hearing you, Richard, because you're on mute. Okay, so Richard is, and I think there you are, Richard. We can probably hear you now.
David. Sorry I'm late, actually. I forgot that I updated to Sonoma, the Sonoma system last day, and it takes about half an hour for you to work your way through the new things. So apologies. David, nice to see you. Thank you.
Yeah, we started with some introductions, and I think you probably know most people here, and Manas and Cara from Irish Global Health Network, and Thora from Global Health Program. I think you know Joe Gallagher and Michael. I know you know, and Anna, you know well.
Indeed. Thank you.
If any of you don't know Richard, Richard is the chair of the Ireland Africa NCD Alliance, and I think has been the driving force that's helped get it to where it is today. So we did mention that a bit earlier, Richard, and mentioned that most people are connected, actually, who are here today are connected through that, which is a great way of bringing people together. So we were just getting on to just opening up for discussion and saying this is a place for us a chance to have a discussion around our work and our partnerships in NCDs, to discuss our things we've learned, the challenges we faced, and maybe some things, innovations and creative solutions we've come up with. And just to maybe hopefully through the discussion will be helpful to each other, to learning from each other, and maybe coming up with some ideas as to how to strengthen this whole work. Because I think through the NCD Alliance, I think that's a place where there's a lot of activity now, and there's challenges of how do you then actually take things, translate it, that the expertise that's come together through that group into effective action in countries, and what are the obstacles to that, and how might they be addressed. And then I think from our side in the HSE and in the Irish Global Health Network we're always kind of thinking, well, how can we support that, what you're doing, other things that, you know, we know understand those challenges, are things we can hopefully work with you on. So we'll open it up for discussion, and just we start the discussion and just share your ideas. We're not such a big group. I don't think you need to be too formal with sticking your hand up, and this is a big queue. We can manage it, but otherwise, let's just we're in a room together. Let's just chat away, and we'll kind of steer the conversation, maybe to just keep us on talking about the right things. Would anyone like to kick off with some thoughts?
Well,
I suppose, will I start then, just to say, as a recipient of the ESTHER funding, it obviously makes a big difference to the work of any organisation. It helps you to formalise the plans. Even doing the application is a great way of getting agreement among all the parties as to what exactly you want to achieve. And also makes you look at what the outputs are going to be from any monies that are spent. So just to say thanks, it has been great to receive the monies, and that even the whole process is very worthwhile.
Here, Anna. I would completely agree. And it's helped us really start in a concrete way. And I suppose we have already seen a concrete movement by two of our nurses going to Togo and giving a course, as well as forming a partnership really with the Togolese National School of Nursing, which is great. We now seem to have sort of reached a little bit of a dead end in the road. And of course, it always comes down to funding, I suppose, really. And it's not that we've really haven't tried lots of things, but we don't seem to have scored recently. And at the moment, we're looking really for more avenues for funding. And of course, I'd be very glad to hear Joe's comments, because he's been extraordinarily successful in fundraising. I suppose in a way that the ways that we've gone about looking for funding is to go to the next level of grant awardeeship, I suppose, which is probably the Erasmus funding. And Daniela, who I'm not sure, I don't think Daniela's with us, but she is a senior nurse in DCU and has been a very active part of our alliance. And she has actually got a couple of Erasmus Plus grants running. So she's well versed in applying and sorry, my dog's behaving a bit strangely here. Yeah, she's well versed in applying and administering Erasmus grants. But the problem we've run into, the first set of problems we ran into, was that we need a second European partner. We have a firm partnership between ENAM, which is the Togolese National School of Nursing, and our alliance, stroke DCU. But to make ourselves eligible, we need to also bring on board another European partner. And this is for a project that essentially is going to train all Togolese nurses, all of them, through channels that have already been tried and tested in Togo, in the basic recognition, diagnosis, and basic treatment and lifestyle advice for people with diabetes. And of course, that would include gestational diabetes. The NCDs are very, very important. I should just stress this, is that SDG 3.2, I think, is the one that covers all the common NCDs, but SDG 3.1 and 3.4 also look at the health of the mother and child, maternal and fetal health. And of course, gestational diabetes is one of the biggest causes of maternal and infant mortality in the world. So there is a pressing need for us to progress this cause. And of course, we have plenty of expertise on board. I mean, hugely, people with international reputations. and international representation on things like the International Nursing Council and people writing protocols but we're looking for really a third partner. And we found that very difficult. That partner just really needs to fulfill a few functions. That is, perhaps be expert in presentation and fluent in French to really help convey our training methods. And it's a ready-made project, but unfortunately that hasn't materialized. We haven't been able to find it. I've tried all sorts of things. And in fact, the DCU people then put us in touch with things like the Coalesce funding and the funding through I think it's community social, something like that, which is all part of of Irish Aid. And we've really reached a sort of another blank, because Irish Aid seems to prioritize certain countries, and I think that's probably reasonable. But they also have helped many, many, many other countries and NGOs, but there seems to be a distinct lack, and really we're not really eligible to apply for help in any of the sort of offshoots of Irish Aid or the Department of Foreign Affairs, which is quite disappointing, because, you know, one would hope that there would be a small packet of money left aside for local initiatives, which have already tried and tested with established partnerships. But it just seems that certain countries have priority, and obviously that's reasonable because governments have to plan for budgetary dispersal, etc. But we're not really getting anywhere with that. So those are sort of the worries that I have, because I don't really know where to turn to next. I have a small amount of money for my project in Togo.
Yeah,
but interested in what Joe has to say, David, and yourself, because
just before coming on to Joe, because I think Joe and I know about Joe's very successful funding application recently. But could you, Richard, say something when you talk about amounts of money, of the kind of amounts that you're talking about that you need in order to be able to progress the work?
Well, the Erasmus grant is pitched at about 60,000.
But not thinking of any particular grant. But if there was to be funding available, what is it that the kind of funding you would need for what you're trying to do in Togo? Can you put for it to be useful? Like, clearly a 10,000 grant isn't enough to do very much. You don't need 10 million. So no. Is there an amount that because this is something we're having discussions with Irish Aid about, you know, mechanism for funding grants in partnerships, and it would just be useful to get some sense of what we should be pitching that at.
I'm not sure, David. I would like to give you a off the cuff answer. I think I would need to do that properly, because I think if I were to attempt to do a guesstimate, could be too high, which would be bad, and could be too low, which would also be bad. But I need to get together with Daniela. Anna, I don't think we've got that far, have we, with...
No, but I think we probably are fair to say somewhere between 50 and 100,000, yes, based on the fact that this needs to be probably a 40 to 60 minute educational module that's delivered through an online platform. But equally then we need to look towards licensing going forward, and it's something that we would build into any funding application to ensure that this is a standalone module that can be accessed by all the nurses in Togo and surrounding areas. This is a pilot project initially on diabetes, but it's about delivering it through an already agreed platform that works in Togo. And therefore, it has been used in other countries in Africa as well for the COVID education. So it's an established platform that it be utilised for a new educational mechanism and offers great potential.
Yeah, no, that's very helpful, because I wasn't just thinking just about even this particular project, but I think that gives a good sense, I think, of what we hear from other partnerships, that's the kind of scale of funding that's required if you're going to do some kind of project like this that is going to have some national reach. It's got to be something getting up to that level. Maybe Joe, is a good time to let you come in and just maybe to give your thoughts on
David,
your own experience with funding and maybe just your ideas on where we might.
David, may I just finish off what Anna? Not that I need to. Sorry, Joe. 2 seconds. That would be about the sort of level we were thinking of. And secondly, the WHO has actually gone in to the whole West African states and actually written protocols for treatment and recognition, etc., of all the NCDs. And in fact, we're bound to use that because they will withdraw funding if their protocols and recommendations are not adhered to. It's called the HOPEN, WHOPEN protocol, specifically tailor-made for West African countries. So the content is there, and we're just looking forward to just pushing the thing out. Sorry, Joe, interrupt you. Go ahead, please. I'm sorry.
I hope they can. And thanks. I think it's a great chance to discuss all these issues, which I suspect are common across not only our projects, but everyone's projects. And I think, come back to your question, I think there's one is the amount, and the other actually, if it was multi-annual, you was in one of the challenges, you do a grant and 6 months later you have to do another grant, and you actually consume a lot of resource in trying to write the grant and write the reports. If you had a sort of a block of funding that you said, right, this will last for 2 or 3 years. Obviously, you could have reports in between. That would be, I think, great, because then you could also plan a little bit more sustainably. But to echo Anna's first comments, I think the ESTHER grants have really helped us get things established and on the ground, and as Dick said, to make us all think hard about what we're doing and why we're doing it. So thanks for that. On the Erasmus, certainly. So Erasmus, I came to rather late, only this year, and just for those who know, we got a grant recently which is called Victory, which is looking at virtual exchanges between students and trainees in Ireland, Zimbabwe, Malawi, and Hungary around a variety of conditions. And I suppose that the aim of it is to encourage people to discuss, how is our NCDs managed in these countries, and that might be exactly what we're focused on. But I think that funding also allows us to use some resource to develop other processes and procedures. So I think you're right to use that is really helpful, and increasing there's a focus from the EU on Africa, and I think that will only increase in the near future. One thing I maybe have with Dick is I have a colleague in Hungary who's an absolute, he's like the matchmaker in the Stunvarna. He can match anyone to anything. So I might have a separate conversation with you on what your needs are, and he'll get out his book and see can we find some way to pair you up. But I think I've no doubt that Robert, who's my colleague in Hungary, will be able to find someone who would match what you need. So certainly that's something we can work with. I think one of the big challenges in terms of funding is that NCs just don't get attention. I have a great picture of the pharmacy in the Rural Hospital in Malawi, and there's this beautiful pharmacy for the HIV and TB drugs, and then there's this decrepit shelf with nothing on it for the NCD drugs. That's my experience. I'm sure it's the same in Togo and many other countries that it doesn't get, and so it's very hard to get funders to see this. It's changing a bit, I think. So I think things like the Erasmus grants are a really good way to try and get some resource in to help with it. The Gates Foundation have a call at the moment which is focused on women's health, but interestingly they've excluded NCDs from it because they're going to put a separate call out for NCDs and women's health, which might come back to your gestational diabetes. And it's only 2 pages long, the grant application. It's the shortest you'll ever get. So it's really, really helpful. So I'll certainly keep an eye out for that as well. I think one of the challenges, and I think you've already done, linking with universities is very helpful because their research offices are there. In terms of grant administration for anything beyond the smaller grants, that they have the ability to do that and form those partnerships with it as well. So I think there's a lot of commonality around what we're doing, and just listening to what you're saying about education and the needs. I think that's an issue. One of the projects we're looking on is trying to develop family medicine training in Malawi, and sometimes it's not just about the money. I think it's about the expertise around what are the technologies that you would use. How would you deploy them? I'm bewildered. I sat down last night actually and looked at even the UCD have a technology enhanced learning website, and I think I was more confused at the end of it than when I started, because there's so many opportunities and I don't know what works and what doesn't, and then what works in Togo and Malawi compared to what works in Ireland. So We've used Moodle, which has worked very well, but I don't know, are we using it to its full capabilities? And I do wonder if we could in some way broaden our reach to other groups and faculties, whether it's in IT or education or Google, or these different entities who may say, well, listen, that doesn't even cost them money. They have the expertise that you couldn't buy, because it's someone that say in 2 minutes, this is what you need and this is what you don't need. And that might have been something maybe from an ESTHER point of view, to have something that's maybe not so much focused on healthcare, but on what tools can you use in developing partnerships could be useful. There's such a variety. Like WhatsApp has been a game changer, I'm sure, for everyone, but there's probably many other things that we could utilize, and companies that may be able to say, well, listen, this is how you can use our software better. That might be something that could be interesting. So I think those are the challenges of funding and raising awareness of it is really difficult. Like I was really struck. We did a survey in a rural area of Malawi just earlier this year, and it was 400 houses we went to. And we asked them what are the biggest health problems they have. Just before we came on, so the biggest was malaria, the second was hypertension, the third was asthma, the fourth was HIV, the fifth was epilepsy, the sixth was diabetes, the seventh was cancer, and TB was down after that. And if you asked a major funder what are the biggest health priorities in rural Malawi, they probably start with HIV, TB, and malaria, pneumonia, and perhaps stop. And I wasn't even, someone who was really passionate about NCDs, wasn't even quite aware of how much of an impact it has. And I think maybe one of the challenges is that NCDs have so many different conditions. And so pneumonia is a discrete thing and HIV is a discrete thing, but everyone treats diabetes and asthma and hypertension almost as separate things. When you put them together, they're huge. And even in this one on their own, they're an issue. So it is about making people a bit more aware, I think, of this. This isn't, as you said, David, something that's just a European problem, and it's going to overwhelm health systems if we don't get on top of it.
Thanks, Joe. Yeah, you brought up a kind of there's quite a bit of food for thought there. So maybe we're going to maybe could delve into some of those a little bit more. But so there's the funding. We started with that. There's the whole issue that you brought up there of the raising awareness and how NCDs aren't getting the attention that really they merit based on the size of the problem, and then the whole thing about some of the technical solutions. So we might kind of look at those, but maybe just since we started with the funding and just where we might go with that. So I think the point's being raised about you need bigger funding and you need multi-annual funding, and certainly with the kind of work that you've spoken about, Richard, in Togo. This is a long-term project. This is not something you're going to start and finish and then it's done. It's more of a program. And that's the idea. That's why we promote partnerships, because they lend themselves this way of working year by year. But if your funding streams don't match that, then you're getting into difficulties, like you said. Now, I think you talk about Erasmus funding, that's as roots. And I think everybody has that challenge of where do you get the funding? But just I'm thinking of what we can do from, I suppose, HSE, ESTHER point of view to support that. We are looking at we get our funding from Irish Aid, and we are hoping that over time that funding will increase. And the question is then, if the funding increases, how do we use additional funds? And what we're putting it to now at this point to Irish Aid is that what we've done over the last number of years is to help partnerships get established. That's why we set up the ESTHER Fund. It wasn't to run projects, it was to help develop these strong links between our health services and our health institutions with other countries, on the understanding that if you have those strong relationships built up and these strong links, then you've got a very good platform to do effective long-term capacity building in the health sector. And so lots of these projects have started and they've got well established, and now they're well established, they're ready to take on these big projects, but then the money isn't there. So we're now in discussion with Irish Aid about this, and we're saying, yes, we need that funding for the startups. That's relatively small. You don't need a lot of money to start up your partnership. And we've seen the success of that with the ESTHER grants, but you do need more sizable grants. And so we are putting forward that idea that we would like to be able to have maybe a similar type of grants arrangement to the current ESTHER ones, but they would be for projects and they would be multi-annual, so that you could be of the level that you're talking about, that might be where a project might be 50,000 in a year, but it might be over a few years, but something on a higher scale than before.
I think it's great, David, and it's not an easy thing, I know, to achieve. And if these so well done on pushing it, and I think it would help, as you said, once particularly for the established partnerships to really give that next step forward.
See, we've one person's joined. I say Augusta. I don't recognize the name. Can you introduce yourself?
I think she's muted.
This the Irish Global Health Network screen, is it?
Hi, Augusta. Augusta is from the University of Limerick. And more than that, I'm not very familiar, I'm afraid, but you're very welcome, Augusta. If you wish to introduce yourself, we'd love to hear from you there, but at the moment you are muted.
Public health student from Limerick, yeah. Just putting the text in.
I thought, yes.
Okay, you're very welcome, Augusta. Yeah, we did introductions earlier, so it's nice to have you on the call. So I think we'll take that as maybe with the funding as maybe a big takeaway message. I think that we're hearing this a lot this year from partnerships, that funding is an issue. So we'll certainly be seen as one of our functions in supporting NCD work will be to try and support you with opportunities for funding. The issue then maybe to be, Michael, are you looking to come in there?
Yes, just struck me that
do shout
at the moment we should be getting 0.7% of GDP for overseas aid, and we've 16 billion sitting in the bank waiting to be tapped on. Can we not get some of that? Is there a way that we can get some extra money from them?
I would say that earlier this year I was at a workshop or a meeting that Irish Aid convened for people in their programs all around the world to review progress with their policy, A Better World. And at that, there was one of the ministers spoke at that, and that is initially spoke about Ireland being well below the 0.7% and how might Ireland get there, and that's still an ambition of the government. It's a long way off, and I think it was explained for various reasons how we're increasing, but we've some way to go. I don't think we can influence that debate meaningfully. I think there's a lot of people are trying to influence that debate. I think my feeling would be that where we will get maybe the most opportunity is to try and have an allocation of more resources for the kind of work that we're involved in, because it is very small money in the context of a budget of 1 billion euros. Then the kind of funding we're talking about for work through partnerships is really quite small. So I think if we can influence that and this might link with the message with what Joe said, that NCDs don't get the same attention as communicable diseases like AIDS, TB, and malaria. Some of that in Ireland and in Irish Aid is historical, that Ireland took a lead in responding to the HIV crisis and developed a lot of funding support for communicable diseases. So having built up that, I suppose, that niche area of focus, it doesn't easily necessarily change that, and there's still funding going into that area. But it's not just in Ireland. I think it's a collective thing across a lot of the donors, that while NCDs are creeping up on us, the donors are not responding to that. And the thing about communicable diseases is they affect you now because you're sick with them now. With NCDs, you'll get them now, but they might make you very sick for another 10 years or so or longer. So there isn't that same sense of the problem being an acute one. And I think that's something that a role we can play. And I think having the NCD Alliance, I think, is a great opportunity to play a role in getting out that message. And maybe I don't know, do you think that's something that the Alliance could do,
Well,
is to produce some very, very good information that will communicate the message around with good backed up by data that we really need to take NCDs very seriously in Africa right now.
We had a speaker from the NCD Alliance speaking to our group. And I think the feeling afterwards was that there wouldn't be much use to us. But most countries, both low-income countries and high-income countries, are members of this group, the Alliance, which is based in Switzerland. I was just wondering, could we look at two aspects? One is that we might make links with people that you're looking for a second person, a second country or whatever, to come in on a project that if we were members of the Alliance, we'd have a better chance of making those contacts. And they also have their own bursaries, which can be given. Now, they're mainly given to low-income countries. But if we could make an issue for ourselves by linking in with other European, particularly European Union countries, I think more than the ones outside, because I think the EU have bursaries for countries working together from Europe in the third world or in Africa. So,
well, maybe others might have views on that, and I think there's you might need quite a bit of capacity, or we might need that ourselves if we're from an Ireland going to engage at that level. And we are a small country with, we might have a good few people. There might be good people in the Ireland Africa NC Alliance, but it's still very small compared to some of these big organizations.
Yeah.
And maybe being small means we tailor our work to what we can do as a smallish group with relatively small resources. And I think that the way we work with a small number of countries through these partnerships might be the best way we can have impact.
Yes, I'd agree completely.
Richard,
I think I'd agree. Michael has a wonderful ability to, and I mean this sincerely, of finding alternative routes to the goal and refreshingly clear thinking about alternative routes. I think in Ireland we probably are going to need to keep our feet on the ground and not have a particularly overambitious projects. And I think we're very dependent on people like yourself, David, because it's very hard to really persuade the Department of Foreign Affairs and Irish Aid to change their thinking. They have policy that I'm not quite sure where it comes from. I know some of it is based on the fact that there are certain countries have Irish embassies in them, which probably makes communications and dispersal of funds easier. But any contact I've had with Irish Aid has been sort of very focused or almost tunnel vision. I don't mean to be rude when I say that, based on the policies against communicable diseases. So they're holding fast to their aim of the WHO aim of eradicating communicable diseases by 2030. And but I think it would be very helpful if we could even just try and influence their thinking by meeting them. But I've not had any luck. That's why I think it's very important with people, influential people like yourself and your department and Thor, etc., to be perhaps plugging away, and we be dependent on that. I think, because I'm having absolutely no luck communicating with them. They're very helpful and polite, but it seems that their policies are sort of written in stone, really.
Yeah.
I do think that there are other aspects that we need to explore, and I think the partnership model really lends itself to that. And I'm thinking more of the advocacy things, because there's no doubt that the high-level committee on NCDs said, this is a major problem, and every target we've ever set successively has been breached and become obsolete, and they have to keep rejigging their targets and their goals. But they say that it will not happen. Nothing is going to happen unless this goes to the highest level of the partnership countries to include the head of state.
Yes.
That bad. Now, I do think that speaking from the Togolese point of view, I think that there really could be a little bit more of a buy-in. I think there's no reason why they shouldn't be able to go to the president or whoever, or to the national broadcaster and say, we want 30 minutes every night or 30 seconds every night on non-communicable diseases. Because, you know, there's no doubt, and Joe, I'm sure, will back this up, we can do a project on a diabetes center, we can do a project on an NCD center, we can do train the nurses. But, you know, there has to be everything from public education to a freeze on fast foods within a mile of schools, sugar taxes, and just general awareness. I think that maybe we should perhaps develop, as Anna has also really championed, the formation of an advocacy branch within our alliance. And I think we recruited a person who I think has been quite busy, but I will make contact again, who's a high-level sort of businessman. People like Michael, people like Annette Kennedy and Anna herself. I think maybe we do need to push the advocacy role both in the southern countries and in the Department of Foreign Affairs here and in Ireland. You know, at the moment, there's this belief that communicable diseases still kill more people in the world than non-communicable diseases. That's probably true in some low-income countries, and that's mainly due to lower respiratory tract infections in low-income countries, in infants. And I'm sure Joe will agree with that. And that actually is stubbornly difficult to shift. It even occurs a lot of people and babies in developed countries. But certainly as countries move from low income to low middle income, then the non-communicable diseases start shouldering their way into the sort of the perpetrators of mass mortality as countries become more, and this is happening because the rate of growth in obesity is greatest in number one in the world in West Africa, secondly in East Africa, I think thirdly in North Africa, then South Africa, and all the Africas before the Far East, etc., come into the Polynesian islands and etc.
So Richard, you're very kind of clear about the need for the messaging and the messages, and maybe just others might have some thoughts on that. I mean, there's no doubt that you want to try and change kind of people's understanding of it. And you talked about with Irish Aid, I think sometimes the people you work with are not people who are technical people in health. They're people who are managing portfolios of support. And that's different. And they won't always necessarily have the time to be involved in those type of discussions. And they would probably feel that anyway, it's the key policy decisions in Irish Aid are made well above their level. And health is not a high priority among different issues within Irish Aid. It's a priority, but it's not one of the top ones. So that is a difficult one to address. And I think the challenge might be is how to over time to change the thinking on that, and who can do that, and how is that something you could do through the Ireland African Alliance to develop some advocacy materials, you know, with so that people are au fait with some of the key messages, because I think people don't know the facts, and there's a lot of misinformation, or there's a lot of people can interpret the information that they read differently. So there might be something that's useful to do, and then in repeated engagements with the likes of Irish Aid, we can be repeating the same messages. I mean, what do people think? This is something that can be done, that should be done?
I think you're right, David. I think part of the issue is that sometimes there's so much to be done that it can become overwhelming. I can imagine if you're sitting in Irish Aid and we come along and we said, "Listen, we have all these things we need to do." Sometimes it's like, "Oh God, I'll stay away from them." That's too much. We can't manage that. So maybe one of the things we could do is come up with sort of the three key messages that are sort of our mantra, that and that's actionable. And one thing that struck me as you're talking, Richard, was HIV is a big issue still, and it still keeps people's, in terms of funders, their mindset is on it. Perhaps, the fact that they have such high rates of diabetes and dyslipidemia in those areas as well, can we work with them to develop sort of approaches that integrate into the HIV space? So they've very well funded programs in for HIV and TB, and is there a way where we can say, well, listen, okay, we're not going to create a parallel process for this, but you do have a big problem. Your people with HIV are not going to die from HIV now; they're going to die from heart disease and diabetes. But perhaps we can help people work on that, and I suppose HIV in particular is nice in that it's a chronic condition in many ways now, and there's clinics and there's follow-up, and it's about how we can build on that. Maybe it might be an approach that mightn't be as threatening to funders or to policymakers as an approach. I'd be interested in what people think. Is that something that might be worth exploring?
Yeah, I like the sound of that. I was wondering, this is something again, Richard, and the Alliance that could think about is having a set of materials that might include even some PowerPoint slides, so that when there's different events on, different members of the audience could come and speak confidently about NCDs, because they know the fact. You know them quite well, but probably lots of people wouldn't feel they're on top of it enough to be able to speak about it. And if there were a number of very clear key messages that were put out there, I mean, if you had somebody at all the big conferences in Ireland, there was always somebody who was out there speaking on NCDs. The message will get around maybe over time.
I have a friend in Denmark who's telling me that in their NCD group is sponsored by the Danish Cancer Society, and that they pay all their bills and so on. And we're about the same size as Denmark. And so we could try and, looking at their website and how they have done it, could see if we could link in with them. If you're looking for a link in from another European country, it could be useful.
Yeah. I wonder about moving on to I think the issue that Joe brought up about technology and technical solutions. I think this, to me, there must be a big opportunity here with very rapid advances in technology, and some of these are low-cost technologies. That to be able to scale up solutions for NCDs in the country in Africa. Now, so how does one go about that? And just from experiencing in countries, seeing that that companies producing some of these new technologies are marketing their technologies in those countries. And so it becomes like kind of a supply-led thing. So they go into the country and say, this is the solution, and I haven't even looked at what the need is. And there's all these techie solutions for everything. And I'd say it must be very hard for countries to know how to take up these new technologies, because there's so many coming in different directions. And yeah, just wonder is there a good approach to that? Is there something? I mean, Ireland is a country producing with a lot of technology. Are there companies in Ireland that are producing some things that could be a partner in countries? But even if you know there's a company, how do you know that what they're producing is really what's needed in the country we're working in? Maybe they're not ready for it. Maybe it's the wrong solution at this time.
Can I come in there? Just I know we're talking about technology, and that's great coming from us, but you've got to remember we're working with the basic healthcare system or the nursing schools or universities in these countries, and they don't have access even to the latest technology. So it's even down to getting laptops and computers for them before we even talk about what kind of licenses need to be purchased in order for them to make effective use of those technologies. And yet every student in those schools will have a laptop, but the tutors and lecturers in it have difficulty accessing that level of technology for their own use in the classroom.
Yeah, that's a good point, Anna. Yeah.
I think it's a good point, Anna. And actually what we found when we started trying to use Moodle was that actually the smartphone was the key to everything. It's very hard to develop these tools on a smartphone, but they can be deployed relatively well on them. And another interesting fact from that study we did in that rural area, there was only 10% of people had any form of electricity, but 60% said they got most of their health information from phones. So you're right, I think, and it's not about using technology we might be familiar with in terms of a very fancy virtual reality environment, but it could be as simple as how can we use WhatsApp, text messages, very basic platforms that we might use, but the reach is huge. And as Dave will know, like during COVID, we tried this Facebook campaign, which I think really taught me how far you can reach with social media very quickly, for good and for bad. So, but I think it's probably go back to your idea, it does need people who have that sort of technical knowledge, whether it's a company or a student in the university. I think there's so many people that have skills and abilities in this area, and it's about matching that and tempering their knowledge as well. You don't want someone who is going to say, oh, listen, you need this, but you'll need a gigabyte of broadband. It won't work in Wicklow, where I live, either, to these other areas. But I think it does have the potential maybe to reach out, and even learning what are the key things we need to ask. I think when you look at the technology could be helpful, as in if there was a sort of almost a checklist, we could say, right, this is what we need to know before we decide, is this something that we can use or not? And it may well be that it's through using students or the university departments. That might be a way, or companies. You go down the quays in Dublin, it's full of Google and Facebook and all these people who probably know better than anyone how to access people in these countries, including ourselves. So yeah, it's an interesting approach.
Yeah, and just thanks, Joe. And I've just seen Augusta has just put in a comment in the chat saying it's important to have simplified technologies and also work with the local team to figure out what suits the needs of the people. And I think that captures well. I think what's the essence of what I think some of you have been saying about that solutions needs to be kind of appropriate technology and local, that fits to the context, and that it is based on their needs, and that the way we're working with partnerships, maybe that's the kind of technology approach then that we need to be taking.
Actually, David, on an approach that might work, and I saw this in Malawi, and I'm going to really show my total acknowledgement, but they had this hackathon where literally they had these IT people sitting in the room, and you came with your problems, like speed dating for things, and you came with your problems, they came with their solutions, and it was sort of this rapid fire, okay, this is what I need to do. And maybe something like that, maybe that's something we could try and have sort of a matchmaking type process, something very simple in many ways, but very quickly we'll figure out do some things work or not work. It might be an interesting approach.
Yeah, that sounds interesting. All right. I think with these, whenever I hear about these new technologies, I always go and say, well, what's the need and who's expressing the need? The companies producing technologies will always have their idea of the need because they have the solution. And I think it's one of the challenging things when we work in partnerships is we go in listening mode. That's the idea of a partnership. It's that if we're working in their country, it's with them on their issues and their problems as they see them, and we're supporting them in that. So I think that's probably very relevant when we're looking at brick technologies, is that we have the right starting point for the discussion, which is around the local needs and the kinds of solutions that are appropriate to the local situation. And when you understand the needs, then you can say, well, is the technology addressing that need as they've expressed? And that's about then, but I think having that good understanding of the local context.
Could I possibly just maybe ask you there, Joe, was there one particular problem that maybe you've identified that you are currently looking for a technological solution for, or is it just more general?
There's a couple, so rather than one, and they're sort of slightly different. So one was the sort of e-learning type issues that we were talking about. And we ended up using Moodle because it was sort of designed to be used on, it's not the fanciest one, but it works well on sort of relatively simple phones. But for instance, I'm not sure if we're using it to its best ability, or could we use it better? That's one thing. I think the other thing that's probably common to NCDs, and I take everyone's opinion, this is, we developed sort of a clinic registry, which I think is really helpful for us to be able to monitor outcomes. But again, we're using a piece of software called RedCap, which again is open source and free, and thanks to ESTHER for helping us support set it up. But again, you may find someone say, well, no, I'd use this is easier to use, or this is better. So there's probably a couple of common use cases that we would all utilize. that we could use. One of the things that and again, this came from a colleague in Malawi, was, because of health literacy issues, we ended up using WhatsApp audio messages for diabetes education in the field because people couldn't read. So, but again, I know when I use WhatsApp, there's all sort of automations that you can build into it. So we're in a very laborious way, sort of texting people manually, but maybe we're just not doing it right. So it's often maybe not about very high tech solutions, but someone saying, "Oh no, that's not how I do that," and maybe it's matching what we need to do. As you said, Cara, maybe we have a list of things that we think we need to do, and then people may say, "Well, this is, I think, how I do that." Might be helpful. And a bit like what we learned with the Facebook thing, it was all about short, low bandwidth videos, and it worked. It just worked, and that was just a chance conversation we had with someone. Said, "Oh yeah, keep it to this length and do it in this bandwidth," and it wasn't complicated. And we were very lucky. Nadine had put in contact with a student who really understood it. And I often think students could be great at this stuff, because it's not, in many ways, you don't want someone who has a whole load of technical knowledge and has been in a company for 20 years. You want someone who's sort of willing to try things out and has looked around. They often have better ideas, I think.
Thank you for that, Joe. I suppose I'm just trying to kind of link it in as best I can with the work of ESTHER and the potential that is there within our network. And I suppose, kind of like, on one hand, we have our newsletter, which has its readership of, I think, probably most, if not all, of the partnerships that we have funded. And there's such knowledge kind of within that. And at the same time, I struggle then maybe to get news from partnerships to share. But maybe that news can also be, asking a question of other partnerships. So, Gori, Malawi is facing this problem. Does any of the other partnerships, would you feel like getting in touch if you have encountered this before and have other ways? So maybe there's kind of something there that we can use the network in a way when we can identify something that's quite specific, and see if we can just kind of share the problem and share the learning on it.
I think so, Karen. I think even then also, if we had a list of things, I think a lot of universities are often looking for students to be sort of involved in these sort of, not necessarily in depth, but almost out of anywhere, you'd say, well, listen, can you tell us what you do here? It can be almost a student project. So as you know, we had colleagues from Malawi over in September, and we had to talk in UCD and found out the School of Architecture and as well know that this is how we do this. You do this, and you don't need electricity, you don't need that. And all of a sudden you go, oh, right, okay. And like, to them, it's like, well, why are you doing it that way? And they have these skills, and it really took them 2 minutes to sort of look at a solution. I think in some ways, maybe if we collated a list of issues and maybe say, well, these are the common things, and then I think you'd find a lot of university departments say, well, this would be great. We'd love to send some students to try and figure out a solution to these. And it may or may not work, but I think be low intensity in terms of we're just asking people to talk through them and think about it. Yeah, well, it's often those opportunities. Yeah.
Something we could consider in the partnership forum, Cara, that we, maybe do a session around that where, let's have a discussion around who are the key people, even to just do some kind of workshop on technological solutions or things that work well. It could be simple solutions, Joe, as you say. It's things that we haven't thought about or using simple solutions to maximum benefit.
And I think a lot of what we've been talking about too are communication technologies, and that's communication just for the operation of the partnership, but also communications for education and learning and training. And I think what I think is very striking when you talk, Joe, is just how it's what can be done with the technology we are familiar with that aren't necessarily the most advanced technical ways of doing things. And I think you won't do something often just because you didn't know that was an option, or you never thought of it because you just didn't think of it. So it's maybe that's something we can be thinking about, how to tap into very specific areas of learning like that, with examples of tools and approaches that people have used that have worked, that someone else can say, oh yeah, I never thought of that, but I'll do that now. I mean, even for us, with our communications, we're doing a lot of stuff by email and wondering why our partners aren't always responding to us, and then find that everyone communicates much better with WhatsApp. Well, we know that now because, well, it took a little while to appreciate that. It wasn't a problem that they didn't want to communicate. It was a problem that we weren't using the right communication methods with them. And we just had to figure that out and appreciate it. And then we adapted. But I think we're going to want, increasingly to do things I'd have hybrid ways of working. I think as climate change, I think, becomes more of has more of an impact, and we're more conscious of trying to reduce travel. And because the technologies are there, we'd be looking to do a lot of work like education training virtually. And so I think getting familiar with some of the tools for that is in our interest. Are there any other ideas people have on things that would might be useful to discuss? We're not going to just fill the time just if we've if we run out of ideas for this discussion, because we're not such a big group, but people might have other things. Michael, I think you're looking to come in again.
I was thinking, well, one area that we're missing are the politicians. I mean, the United Nations political declaration on non-communicable diseases was aimed at top politicians in countries, and they got a very good response. Now, could we get one or two politicians who have a general interest in NCDs? Very often, maybe one of their family members are suffering from whatever reason, but try and get a political voice on our side could be helpful in many ways.
That's good thought, Michael. Maybe I just might come back to Richard as the chair of the NCD group here. Do we have a patron? Do you have a patron? And might you find someone who might be happy to be a patron? And goodness knows, a lot of these, most people of a certain age these days have an NCD of some sort or another, or a relative with one. There might be, I think that's a good point, like what Michael says, that people, and there might be people of influence. We're not people necessarily of influence because we're not in the political sphere. But if we had somebody working with us who was in that sphere, they could help us take our message in.
I think that's very sound advice, actually, and a great idea, Michael. It doesn't necessarily, presumably, have to be a political person, does it? I think it's somebody who really is a familiar face or is a national figure, and particularly if they're good at sort of short, punchy sort of slogans, seems to be the way that people communicate these days. And so I'll take it on board, and perhaps we'll have a collective thinking at our next Alliance meeting, and perhaps look for such figureheads and representatives. David, I think and Michael, I think that's an excellent idea.
Richard, I wonder as well, you've done a fantastic job in bringing some of the patient organisations on board, like the Irish Heart Foundation and various Diabetes Ireland groups like that. And I wonder, would it be possible to try and encourage them to have even a 10-minute slot at some of their meetings just around global issues, putting it in context? We tend to be very inward looking sometimes on our meetings, and that also includes our own medical and academic meetings as well. And maybe come back to your point about having a sort of a slide deck, almost say, listen, can we get a 10-minute slot at every meeting where we can highlight, to make people think a bit more broadly, and that might raise issues as well, and people go, God, I didn't realize this was such a big deal. And they also have a lot of expertise in pushing agendas and working with policymakers, and they may wish to build it into their work as well, because you've done a fantastic job to bring those groups in, and I think it'd be great to use that expertise to develop awareness.
I think that's right, Joe. There's no doubt. One of the sort of the nice spin-offs was when my colleague, the NCD person in Togo, came over to Ireland to discuss projects, etc. I took him to the sort of clinical leads of many of the NCD programs in Ireland, and he met Ronan Collins, who, as you know, is a stroke person. And Ronan actually, out of the blue, really came out with the fact that there may be the possibility that we could get some funding from the National Stroke Management Committee. And Ronan put that to their committee. I wrote a sort of a succinct but a comprehensive sort of information sheet on our work, and he pitched on the basis that we should be doing quite a lot more for primary prevention, and which actually is also, I think, in the Lancet this week, there's been quite a lot of attention drawn towards primary prevention, and this is what we should be really doing or concentrating more on. And obviously in first world or third world countries, I don't know if that's politically acceptable now, but in low-income countries, that's often the only way they can actually approach these things, because there's no money for diagnostic medicines, tests, hospitalizations, treatments, etc. So at their meeting, Joe said they weren't quite ready for this yet. There were a couple, it wasn't unanimous, but he hasn't given up. And I think you're right, Joe. I think maybe, I was listening to Frank Murray today, so always on the radio, about this particular issue. And, you know, they've got quite a lot of airtime, I think, and perhaps that's something that we could work on. I did try to write to Pat Kenny once and say, because Pat has a family member with diabetes, so that's quite well known. But I really didn't get anywhere with that. But I think, yes, we could go to people like, you know, Michael has a particular interest in tobacco, and we could go to Ash. We could go to the sort of national committees. And there's quite a lot of money sloshing around the system at the moment. I mean, when I did the original diabetes lead, there was nothing, you know, we needed 96 podiatrists and they couldn't employ one, you know, we just spent a lot of time talking and nothing happening. And now, of course, when I talk to the people working there now, they say there's money washing around the system, you know, goodo. So yes, I think that's probably right, Joe. I think maybe that's another way we could certainly put our tentacles out to these different interest groups and form alliances with them, because there's no doubt, you know, if you want to go quickly, go alone. If you want to go far, travel together, you know. So yes, I think that's a great idea. Thanks, Joe. Thanks, David.
Thanks. Just a further thought, thinking back to with the communicable diseases and what we can learn from that. When the Millennium Development Goals were adopted, MDG 6 was to tackle HIV and other communicable diseases. HIV was the one disease identified there. And now the targets also talked about malaria and TB. So they became the big three. But communicable diseases is a multitude of diseases. NCDs is also a multitude of diseases. And I think that's a difficulty in communicating a message, because we're saying there's a problem of heart disease and diabetes and respiratory disease and so on. And it might be just something to think about, whether there's more traction around talk about diabetes and other communicable diseases, or cardiovascular disease and other communicable diseases, or something about how to get that message. And I think certainly here that in Ireland, it's not NCDs, it's chronic diseases. That's what people will understand. So it's about, I think there's maybe some thought about while we have a collective of issues that we can relate in our heads, we see how they can be connected with different causative factors and so on. But for the public, there are different diseases. And are we trying to promote the problem of a whole range of different diseases, or are some more important than others? And how do we get that message across as what's the best way? I don't know, just put that out there.
Yeah, I mean, I thought about that. And I think that one of the things that I find appealing about this is that really is that many people now think that they're all vascular diseases anyway, and they all have a common etiology and pathogenesis, which I think is an attractive concept, because they're just different facets of the same thing, and they all arise from our lifestyle and you know, the fact that many people think it's when people stopped exercising in the late 70s, kids stopped riding bicycles at school, and foods and processed foods began to take off. So I think it's quite attractive to say, look, you know, primary prevention, it treats all these things all at once. And the editorial in the Lancet last week, actually, and if I could almost quote it verbatim, as they said, diabetes is sort of the defining disease, if you like, because that's what the commonest disease in the world, nearly. And they say that our attitude and our actions towards diabetes over the next 10 to 20 years is going to define human health, happiness, and longevity over the next 80 years. It's the defining disease of this century. So, you know,
coming from an endocrinologist, And will somebody else say the same about hypertension or something else?
It's all the same disease, you see, that's the point. I mean, most diabetics, the link correlation between diabetes and hypertension is astronomical. It's about 60% anyway, I think. But
I see Joe has just put something in. Joe, what is that about?
No, I just happened to. I just was googling hackathons. I see, as it's the technology University in Dublin did one just last month on health. To sort of a similar idea of what we were talking about. It might be a useful template.
I was actually at one in Galway before. It was very interesting and really
I've never been at one, Anna.
innovative.
Can I ask how they work? I've heard about them. I've talked about them. I have no idea how they happen.
Okay, so what they did in Galway, again, this was diabetes focused. So they had about 6 groups of about 4 students and 1 expert, an expert on diabetes. And the students defined what their key area that they wanted to address was. And then because they were technology students, they actually developed something then that could be used to address that. So they came up with different ideas. They presented the ideas to the whole group. And then obviously out of 6, I think it was 6, 7 groups that were there was one that was picked as being the overall likely benefit for all people. So they were going to be, the class then was going to go ahead and try and develop that further. So it was really about putting everything into a melting pot and picking out what looked the most likely to have potential to be of benefit.
It's very interesting.
I suppose one thing can I say is that from the conversation today, I think we've moved forward in terms of advocacy for the Alliance, and that you've really developed here a plan of things that we need to be addressing, because unfortunately the advocacy side fell apart when we couldn't get to go to Irish Aid or to present to them. But I think you've given us enough food for thought today to actually put set ideas to that group and get them working on it and moving this whole thing forward in terms of the materials that we need before we actually start addressing different groups. So thank you.
I think this is the great thing about the Alliance having been set up here is that you've got a platform for looking at these things and taking them forward. I mean, there isn't a similar platform, I think, for other issues. So I think it's a great achievement to get it started, and credit to everybody who's involved and played role in that. But I think it's building on that, and I think that from the ESTHER point of view and HSE, I think we can see they're sort of in the background supporting what you're doing, and ways in which we can support that. We'll do that. But I think you've got now the vehicle for taking these things forward, and it's good today now that most people are part of that group.
Thanks, David. It's wonderful.
So I think we've had a good discussion, and we're not far off 4:30. So I think we would probably wrap up in a few minutes. Has anybody else got anything that they were wishing they'd have a chance to say that haven't said? That I think we've had quite a fruitful discussion. I won't try and recap on what we talked about, but we did have, I think, a useful discussion at the beginning about funding. I think there's a lot of exchange throughout about awareness raising and advocacy. And then we had a good discussion as well about how you approach technical solutions and bring them into work on NCDs.
That's super, David. Thank you so much.
Okay, so I think if I might Tara, will I hand back to you then? And
sure. Thank you, David. I think really just to sum up, it was a really great and interesting discussion, and I hope everybody found it helpful. We will have the recording available. Possibly it might be next week by the time we send it out, but if you need to recap on anything, it'll be there in the recording. And as always, if there's anything in relation to ESTHER that you want to get in touch about, please feel free to reach out. That I'm available here and interested to support you and your partnerships. So yeah, just to say thank you so much. Really appreciate your participation today.
Thank you.
So much for
Thank you very much. That was really useful. Thank you so much.
Thanks, everyone.
Okay. Thanks, David.
Bye. Bye.
Thanks.